Hello guys, we are back. By now you've already gone over the entire pulmonary and systemic circuit as well as the arteries and so forth in the thorax and the nerves. Now we're going to continue on with the coronary arteries. So earlier I was talking about the coronary arteries, the right and the left. I was talking about systemic edema, pulmonary edema, and myocardial infarction, and I mentioned the left ventricle is a hell of a lot more important than the right because it has to hold a lot of pressure to build up to send to the body, whereas the right only has to handle the lungs, which are really close. So you can get a significant amount of damage on the right ventricle and still have enough pressure to give to the lungs. Whereas the left, you compromise it just a smidge, and you can lose pressure, and you may not have enough pressure to give to the body. So let's talk about this a little bit. This is a right coronary occlusion. You can see the lumen here is narrowing, which I have significant by these arrows. You can see the occlusion here. It's highlighted by the CT. You can actually, it's lit up like a Christmas tree. And you can see it here as well. So what you're seeing here is they put a stent in to actually, there's a plaque, they put a stent in to actually dilate the artery to get this plaque out of the way, so the coronary artery can get blood flow back there. So the plaque is usually due to atherosclerosis. That means you get the artery starts to harden. It could be due to aging. It could be due to cholesterol. It could be due to blood, like platelets. But typically, it's due to cholesterol and aging. As you get older, the arteries harden and the lumen gets smaller and smaller and smaller. With that said, it means it can clog easier. So if you have clots, like platelets, a high platelet count, or cholesterol, and it creates a plaque, that coronary can be screwed up, and then everything that follows, you won't get blood supply. So remember, the right coronary handles the right side of the heart, the left coronary handles the left side of the heart, and we went over those two beautiful arteries, the posterior interventricular artery and the anterior interventricular artery, and I went into detail of what happens with each of them. So the main key feature here is this can lead to myocardial infarction, and one of the first symptoms you get is angina pectoris to be exact. Angina just means pain, and pectoris is talking about chest. So you get chest pain. That can lead to tissue death of the heart, and that's known as myocardial infarction. You're infarcting the myocardium, the actual the muscle. In this case, it'd be screwing up the right ventricle versus the left, with the right coronary artery being compromised. So you probably get with this side, the pulmonary circuit would be compromised, so you'd be getting systemic edema in the body. Okay, so a good note to know for the exam. Now, myocardial infarction, this is what it looks like. It's dead tissue. This is the left ventricle that got compromised. So you can imagine what artery got screwed up here. Probably it was the anterior interventricular artery here. I want to go over some of the symptoms. We went over pericarditis, and I mentioned they get chest pain. It's localized. It doesn't radiate. And one of the key features I told you was that you can lean them forward, and the heart is able to get some room so it can pump. Well, in myocardial infarction, that ain't going to happen. So what happens is, since this is dead and it's not going to regenerate, the heart will start to compromise, to alleviate itself by increasing its heart rate and contraction of the heart to basically counteract the dead tissue. So it knows it's lost pressure, and it knows it's lost tissue, and it's not getting it back. To alleviate it, it will increase its heart rate and force a contraction, which will lead to diaphoresis. Diaphoresis means profuse sweating. So the heart is contracting at a high rate and is a muscle. So the muscle conducts heat and metabolic activity, which allows you to sweat. So this person can be sitting down and they look like they're sweating like a pig because of that. So that's a key feature of myocardial infarction. At rest, they're just sweating like crazy, and they're getting chest pain. One of the things they'll tell you is that their chest is heavy and there's pressure on it because the heart is having to contract so hard. They feel it, and it always lasts more than 20 minutes. If it lasts more than 20 minutes and it's not alleviated, not by natural means, not through medication, then it's most likely a myocardial infarction. So they get chest pain. It's called angina pectoris. Some people describe it as an elephant sitting on my chest. I've had patients say it feels like there's a bunch of books on my chest, especially my kids, they're students. So they'll say, Doc, it just feels like there's a bunch of books sitting on my chest. So that's another key feature, another symptom that they typically say. Um, they'll clench their fist, their left hand, and they'll put it against their chest. And typically it's called the Levine sign. It's a gentleman that saw this and realized that that pain doesn't just stay in the heart, it actually radiates to the left side of the body, to the left neck and the arm. So the left is more common than the right. The reason being is because, if you recall, right off the aortic arch, you have arteries going to the neck and the arm, right? And the first branch that comes off is the brachiocephalic, and then you have your left common carotid and your left subclavian. And because there's more pressure on the left side of the heart, you'll get pressure on the left common carotid and the left subclavian. And that's one reason they get pain that radiates that area. Now, the reason they get nausea, guys, if you recall, the vagus is sitting right next to this heart. So when this heart starts to pump profusely and very effectively and very strong, you get what they call a vagotone reflex, where the vagus is getting inflamed by this heart contracting so hard, it can lead to nausea down the bottom. So it's a problem, but nonetheless, it can be resolved with anticoagulants as well as nitroglycerin to dilate the blood vessel. But unfortunately, that muscle right there is going to be dead, so you're not getting that back. Now, with an atrial septal defect, we talked about the foramen ovale. Let's say you take your first breath as an infant and it doesn't close. The valve doesn't shut. So the left atrium and the left ventricle didn't build up enough pressure to shut that valve. That allows oxygenated blood to go from the left to the right, which is a problem. You don't want to give your lung oxygenated blood. You want to give your lung deoxygenated blood so it can oxygenate it. So now you're mixing blood. And if you look at these arrows, you get more from the left to the right than right to the left. It's because the left has a higher pressure than the right. So you're getting a left to right shunt here, which is a problem. It was cool to have it as a baby, as a fetus, because you needed that. You needed that blood to get to the right atrium to get to the lungs. Right now you don't. So it's called a patent foramen ovale, also known as an atrial septal defect. Typically they're asymptomatic because the atrium don't handle a lot of pressure. So you don't have that much blood entering the right atrium at a time because the atriums don't build up that much pressure to center the ventricle. But it can lead to pressure, which means you get a hypertrophied atrium, which leads to a right ventricular hypertrophy, which leads to enlargement of the pulmonary trunk because of all that buildup of pressure coming from the left side, and eventually leads to pulmonary hypertension. This is what it looks like in an echocardiogram. This is an ultrasound of the heart. Here's your right atrium, there's your left atrium, and there's the actual patent foramen ovale in there. Typically, it's a heart murmur. It's like a click. Not a clicking sound, it's just a rubbing sound you'll hear. And if you know where the atrium lie, by knowing the second rib, where the base is, you can hear this and you can know that something's wrong with the atrial septum. Okay? Ventricular septal defect is more dangerous because the ventricles rely on heavy pressure to send to the body and to the lungs. This causes even bigger problems. So when this septum doesn't lie as an embryo, you're creating brachial branches to allow the septum to close. Well, if the mesoderm doesn't allow that to happen, you get this, and you get a ventricular septal defect. This is dangerous because the left ventricle highly relies on its pressure to build up to send it out the aorta to the body. Well, if you're not getting enough pressure because it's shooting out to the right ventricle, you may not get enough blood to the coronary arteries or to the brain, and typically they end up with fatigue. They can become cyanotic because they don't have enough oxygen getting to their body, and so they turn blue. Their superficial arteries look blue, and they can pass out and go into a coma and die. I mean, I had patients that had this and didn't know they had it, and then they went to go play basketball, and they literally collapsed there on the floor, and one of them actually passed away. So this is a horrible thing to have, but typically the left ventricle is sending blood to the right, so left and right shunt, just like the patent foraminal valley. If it's large enough, we have to have surgery right away. Smaller ones, we can wait till the heart, at least until the kid's almost a year old, and then fix it. We just tell obviously the little baby's not going to play sports or anything, so we don't have a problem with that. But we wait till they're a year old before they're mobile. If they become mobile early, then we ask them, we renegotiate and probably have them do the surgery earlier. Okay? It's just like the other one. You get right ventricular hypertrophy sooner than later, and then you get right pulmonary trunk hypertrophy and pulmonary artery hypertrophy, and leads to pulmonary hypertension, which is a problem for the lungs. So you can see here, here's the left and right atrium on the echocardiogram down here. There's a ventricular septal defect, left ventricle, right ventricle. And you can even put color in this echocardiogram so you can see oxygenated blood going to deoxygenated blood. It's pretty cool. A patent ductus arteriosus. You remember this little guy sitting on between the aorta and the pulmonary trunk? I told you that before, as a fetus, you're using this to shunt blood to the lung. So that way the lung gets blood while you're in the womb, while you're breathing liquid. Well, after that, you don't need that anymore. You need the right and left pump to work separately as a closed circuit to make sure blood's not entering and mixing. Well, here it fails to close, similar to the foraminal valley, and now you're getting oxygenated blood into the pulmonary circuit, just like you would with a ventricular septal defect or an atrial septal defect. Except here it's directly from the aorta, which has high pressure, directly into the pulmonary trunk. So it can lead to pulmonary hypertension even quicker than the other two, because the aorta is right there and the shunt is really, really quick. Nonetheless, it is not as dangerous as the ventricular septal defect, but it can be. You can see how large it can get, and it can even get more expanded if it stays there for too long. All right, guys. For the cardiac cycle, you have to know this, so I'm going to go over this in detail. We've already been over the valves. I mentioned this already in somewhat fashion, but you do have to know how this works. So let's talk about the atrium contract first and then the ventricles. So realize that both systems are working at the exact same time. The atriums contract at the same time and the ventricles contract at the same time. So here's how this works. You first have the atrium receiving signals from the SA node, and they're going to contract at the exact same time. So they call that atrial systole. Systole means contraction. Atrium is talking about the contraction of that certain thing. So atrial systole is contraction of the atrium. They're both going to contract at the same time because the SA node is giving them both signals. While they're contracting, the ventricles are relaxed and filling up with blood. That is known as ventricular diastole. Diastole means relaxation. So while atrial systole is occurring, the ventricles are undergoing diastole and they're relaxing. The blood is pushed into the ventricles from the atrium, and now the ventricles build up pressure and the AV valves are nice and open. And when the ventricles build up pressure, they're going to shut. But while this is occurring, the AV valves are open and the semilunar valves are shut because you're trying to fill the ventricles up with blood. Okay, so the ventricles are relaxed, filling up with blood, increasing ventricular pressure, and the atriums are contracting and pushing that blood down. Now, after that occurs, the ventricles have to contract. So they have built up with pressure already. They close the AV valves, the ventricles contract, and they shut the AV valves and open the semilunar valves at the same time. So you'll hear the AV valve shut first, and then the semilunar valves will open. And as it occurs, the ventricles push blood out the aorta and the pulmonary trunk and give blood to the actual lungs and the body. Okay, so you're undergoing while ventricular systole is undergoing, you have atrial diastole. What I mean is when the ventricles are contracting, the atrium are filling up with blood for the next go around. And this is what I meant by a closed circuit, but the circuit works continuously. So as the ventricles are filling up with blood, the atrium are contracting. While the ventricles are contracting, the atrium are filling up with blood. They're undergoing diastole, so you can get blood um, as a continuous circuit. So blood is always there, nonetheless. Now, as far as heart sounds, when the AV valves shut at the same time, roughly at the same time, both mitral and tricuspid, you get your first heart sound. When the ventricles contract and push blood out, the AV valves are closing. That's what you get your first heart sound. When the ventricles are relaxed, are beginning to relax, and the atrium are contracting, you get your second heart sound. That's when the semilunar valves are closed. So when the semilunar valves shut, that's your second heart sound. When the AV valves shut, that's your first heart sound. Now let's talk about the EKG real quick. So that was redundant, but real quick. So the EKG, the P wave, is when the atrium are contracting. So it shows as a little blip. There's a small delay before the ventricles contract because you want the ventricles to fill up with blood entirely before they contract. So that small delay is called the PR interval or PQ interval. And then the ventricles will contract is known as a QRS wave. That is known as ventricular depolarization. So depolarization is talking about conduction of the heart or contraction. So atrial depolarization, you have depolarized the nervous system and it is contracting the heart, that part of the heart. So the atrium is contracting during the P wave. During the QRS wave, the ventricular are depolarizing and contracting, which is why it's so big, because the ventricles are such a big muscle. What you're seeing here is as the ventricles are contracting, they're building up pressure until all the blood escapes. So if you're looking here, they're building up slight pressure, and then they're contracting and building up pressure, 120 milliliters of mercury, before all the blood is escaped. When the blood escapes, and now it's filling up with blood, it loses its pressure here. So you have your QRS wave where the ventricles contract, there's a slight delay, and then they begin to fill up with blood, and that is known as ventricular repolarization, meaning the ventricles are relaxed and it's repolarizing back to normal to get ready for the next go around. So the T wave is when the ventricles relax. So when the ventricles are undergoing diastole, it's repolarizing, and the conductive system is getting back to normal to get it back ready to resting membrane potential so it can contract again. Okay, so you can see systole, ventricular systole happens when the AV valves shut, and then when ventricular diastole occurs, the semilunar valves shut, and it's called the second heart sound. All right, now let's go over the cardiac veins. With each artery, I've already been over the arteries. Now the veins, there's a vein for each one. So let's start with the left. You have your left coronary artery coming out this way. Well, there's a great cardiac vein that goes with that. And then, of course, the anterior interventricular artery. Well, there's an anterior interventricular vein that go with that. So the great cardiac vein runs with the anterior interventricular artery from the left side. Okay? So you can see that there. On the right side, you have the with the marginal artery, you have the right marginal vein. It comes from the small cardiac vein. The small cardiac vein will continue down and go to the coronary sinus. And as it does that, it will release another vein that will come from, that runs with the posterior interventricular artery. It's called the middle cardiac vein. So you can see that there are veins coming through that run with the arteries, and they're all going to drain into this big coronary sinus before it dumps into the right atrium, along with the superior and inferior vena cava. All right, so great cardiac vein, the anterior interventricular vein is going to drain to the great cardiac vein, which drains into the coronary sinus. The small cardiac vein is going to drain to the coronary sinus. So the right marginal will drain into the small cardiac, which will drain into the coronary sinus, and the middle cardiac vein, which runs with the posterior interventricular artery, will also drain into the coronary sinus. So as the muscle is getting oxygen, it will deposit the oxygen blood into the heart that way. Now, as far as the conduction system, please know this. Learn the sequence, okay? So right near the superior vena cava, you have your SA node. Right near the septum, the ventricular septum, you have the AV node. So let's talk about this. The SA node sends a signal to both atrium and contract both. I want you to reiterate this. The SA node has its own little conductive system. It is not relying on the brain. It is not relying on the medulla oblongata. It is its own pacemaker. In fact, you need this to work in order for the medulla to actually help with conduction of the heart. Remember, I told you the medulla controls the heart rate. Well, you need the SA node to conduct that in order for the medulla to take over and help out. Without the SA node, all this doesn't work, which is why we have ectopic pacemakers to help out, because the brain doesn't help it and nor does the medulla. So that's why we created ectopic pacemakers, because you need something to help out with that SA node. All right, so once the SA node contracts, sends a signal, or conducts electricity, it sends a signal to both atrium and both atrium contract. There's your atrial systole. While that is occurring, it is sending a signal to the AV node and sending a delay response. Why? Because it wants the ventricles to fill up with blood before you contract them. So the AV node is slower than the SA node in the sense that it has a delayed response. It will send the same heart rate that the SA node said. So if it's 90 beats per minute, the AV node is going to send 90 beats per minute to that ventricle. From the AV node, you have the AV bundle and the bundle branches left and right. The left handles the left ventricle, the right bundle branch handles the right ventricle. There is a slight delay before it reaches the Purkinje fibers down the bottom. They're actually named after a person. Once it reaches the Purkinje fibers, the entire ventricles, both of them will contract, and that is known as ventricular systole. So you can see there's a delayed response. So the sequence is SA node, AV node, bundle branches, and the Purkinje fibers. All right, guys, so I'm going to stop here, and we'll work our way and finish off this lecture.